Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
This module provides a comprehensive overview of antihypertensive pharmacotherapy and toxicology. Since the 1960s, hypertension linked to stroke, myocardial infarction, and sudden death has been managed with drugs. We will explore the evolution of these drugs from first-generation agents, sympatholytics, vasodilators, sodium nitroprusside diuretics, to newer ones, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, direct renin inhibitors, noting their improved efficacy and safety. A key objective is understanding each agent's mechanism of action and toxicologic considerations. While most antihypertensives cause hypotension-related symptoms, centrally acting agents like clonidine present unique toxidromes. We will cover pharmacology, clinical toxicity, and management strategies for each drug class, including special considerations for vulnerable populations and emerging therapies. Antihypertensive pharmacotherapy has evolved significantly over time. It is important to understand the historical development of these medications, differentiating between first-generation agents and newer antihypertensives based on their improved profiles. A general principle of antihypertensive toxicities is that they primarily manifest as an exaggeration of their pharmacological effects, largely due to the degree of hypotension produced. Centrally acting sympatholytics, such as clonidine and methyl-dopa, have unique pharmacologic actions, including central alpha-2 adrenergic and imidazoline receptor effects. Their distinct toxidrome should be differentiated from opioid poisoning. The clinical manifestations and management strategies for overdose of centrally acting sympatholytics should be outlined, including the role and limitations of naloxone and interventions for respiratory compromise, hypotension, and bradycardia. The withdrawal syndrome associated with abrupt cessation of central antihypertensive therapy must be recognized, and medications like beta-adrenergic antagonists are contraindicated in this context. Direct vasodilators, including hydralazine, minoxidil, and sodium nitroprusside, have specific toxicologic considerations. Particular emphasis should be placed on cyanide and thiocyanate toxicity associated with sodium nitroprusside. Diuretic use can lead to major metabolic and electrolyte abnormalities. It is crucial to distinguish between hyponatremia, hypokalemia, hyperkalemia, and hyperglycemia, and understand their clinical implications. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers exert their antihypertensive effects by targeting specific components within the renin-angiotensin-aldosterone system. It is important to recognize their shared risks of angioedema and teratogenicity. The management of overdose of these medications should focus on supportive care for hypotension and the potential utility of novel therapies such as methylene blue and vasopressin for refractory cases. Finally, the mechanism of action of direct renin inhibitors should be recognized. The controversies and potential adverse effects of their combination therapy with other renin-angiotensin-aldosterone system-acting agents also warrant discussion. Hypertension is a prevalent chronic medical condition that is highly responsive to pharmacotherapy. The use of antihypertensive medications began in the 1960s after asymptomatic hypertension was linked to significant adverse effects such as stroke, myocardial infarction, and sudden death. The development of antihypertensive drugs has occurred in generations. First-generation antihypertensives included centrally acting sympatholytics such as clonidine, methyl-dopa, guanfacine, and guanabens. Other imidazoline compounds like oxymetazoline and tetrahydrozoline, used as topical vasoconstrictors and nasal decongestants, can produce similar systemic effects if ingested. Direct vasodilators were also first-generation medications, with examples including hydralazine, minoxidil, and diazoxide. Sodium nitroprusside was another medication in this category. Diuretics, categorized into thiazides, e.g. hydrochlorothiazide chlorthalidone, loop diuretics, e.g. furosemide, bumetanide ethacrynic acid, and potassium-sparing diuretics, e.g. amiloride, triamterene spironolactone, also constituted a significant group of first-generation antihypertensives. Newer antihypertensives with improved efficacy and adverse event profiles include beta-adrenergic antagonists and calcium channel blockers. Angiotensin-converting enzyme inhibitors work by inhibiting the conversion of angiotensin I to angiotensin II, leading to vasodilation, decreased peripheral vascular resistance, and reduced blood pressure. Common examples include benazepril, captopril, enalapril, and lisinopril. Angiotensin receptor blockers, introduced in 1995, antagonize angiotensin II at the type 1 angiotensin receptor, reducing blood pressure by blunting sympathetic and renin-angiotensin systems. Examples are candesartan, irbesartan, losartan, and valsartan. Direct renin inhibitors, such as aliskiren, work by directly inhibiting circulating renin within the renin-angiotensin-aldosterone system. Understanding the mechanisms of action and unique toxicologic considerations for each of these agents is crucial. Generally, the majority of antihypertensives manifest clinical signs and symptoms based on the degree of hypotension produced. Hypertension is a widespread chronic health issue that responds effectively to pharmacotherapy. The development of antihypertensive drugs began in the 1960s, driven by the link between asymptomatic hypertension and severe adverse effects like stroke, myocardial infarction, and sudden death. The evolution of these drugs has progressed through generations. First-generation antihypertensives included centrally acting sympatholytics, direct vasodilators, sodium nitroprusside, and diuretics. Later developments introduced newer agents with improved efficacy and adverse event profiles, such as beta-adrenergic antagonists, calcium channel blockers, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and direct renin inhibitors. For this session, we will begin by giving attention to clonidine and other centrally acting antihypertensives within this broader context. These agents primarily include clonidine, methyl-dopa, guanfacine, and guanabens. Structurally similar imidazoline compounds like oxymetazoline and tetrahydrozoline, typically used as topical vasoconstrictors and nasal decongestants, can produce similar systemic effects if ingested. Clonidine, initially studied for its nasal decongestant properties, was found to cause hypotension due to its potent peripheral alpha-2 adrenergic agonist effects, leading to a redirection of its therapeutic application to other areas. Despite newer antihypertensives diminishing its role in routine hypertension management since 1985 due to improved efficacy and adverse event profiles, the use of alpha-2 adrenergic agonists like clonidine is increasing for a wide variety of applications. These include attention deficit/hyperactivity disorder, peripheral nerve and spinal anesthesia, and as an adjunct in managing opioid, ethanol, and nicotine withdrawal. Clonidine abuse may also be a growing concern among opioid-dependent patients, and it has been misused in criminal acts of chemical submission. Centrally acting alpha-2 adrenergic agonist exposure, though relatively uncommon, can cause significant toxicity, especially in children. In 2014, over 9,700 clonidine exposures were reported to United States poison centers, with nearly 1 in 5 resulting in moderate or major effects. Significant poisoning has also occurred due to formulation and dosing errors in children. Imidazolines used as ocular vasoconstrictors have led to systemic toxicity, particularly upon ingestion. The blood pressure-lowering effects of clonidine and other medications that act on the central nervous system are mainly achieved by stimulating presynaptic alpha-2 adrenergic receptors in the brain. This stimulation increases the activity of inhibitory neurons within regions responsible for regulating blood pressure, especially in the nucleus tractus solitarius located in the medulla oblongata. As a result, norepinephrine release is decreased, leading to a reduction in sympathetic nervous system activity. This series of effects causes a decrease in heart rate, vascular resistance, and arterial blood pressure. The influence of these medications on the sympathetic nervous system is further modulated by nitric oxide and gamma-aminobutyric acid, which may explain some variations in clinical responses during overdose situations. Additionally, imidazoline binding sites are found in the rostral ventrolateral medulla and in the smooth muscle tissue of coronary arteries. Stimulation of these sites appears to lower blood pressure independently of the central alpha-2 adrenergic pathways. Evidence suggests that both imidazoline and alpha-2 adrenergic receptors play roles in the effects of clonidine and similar drugs on inhibiting central norepinephrine release and influencing cardiovascular functions. The I-1 imidazoline binding sites are associated with physiological processes such as cell signaling events, including the hydrolysis of choline phospholipids, and may be part of the family of neurocytokine receptors. Clonidine is effectively absorbed through the gastrointestinal tract, with approximately 75% absorption. Its onset of effect occurs within 30 to 60 minutes, reaching peak serum concentrations between 2 and 3 hours and lasting up to 8 hours. The drug binds to plasma proteins at rates between 20 and 40% and is primarily eliminated unchanged via the kidneys. Other related drugs, such as guanabens and guanfacine, are also well absorbed orally, reaching peak blood levels within 3 to 5 hours and exhibiting large volumes of distribution. Methyldopa, unlike the others, is a prodrug that requires metabolic transformation within the central nervous system into active compounds like alpha-methylnorepinephrine to exert its blood pressure-lowering effects. Transdermal patches containing clonidine pose unique clinical challenges. These patches contain a considerably higher amount of the drug than is typically delivered over a week of use. For example, a patch designed to deliver 0.1 milligrams per day contains a total of 2.5 milligrams. A large portion, ranging from 35 to 70%, of the drug remains in the patch after use. If the patch's outer membrane is punctured or if the patch is ingested, it can release a significant amount of the drug rapidly, potentially leading to toxicity. Discarded patches are also hazardous, especially to young children, because accidental contact or ingestion can cause serious health issues. In therapeutic oral doses, clonidine and other medications that act centrally to lower blood pressure generally have little effect on peripheral alpha-2 receptors, the peripheral sympathetic nervous system, or normal circulatory responses to exercise. However, when serum concentrations increase, such as after intravenous administration or an overdose taken orally, stimulation of postsynaptic alpha-2 adrenergic receptors in the periphery can occur. This stimulation may result in increased release of norepinephrine, leading to vasoconstriction and an initial rise in blood pressure. This hypertensive phase is usually short-lived because the powerful central nervous system-mediated inhibition of the sympathetic nervous system becomes the dominant effect. As a result, blood pressure then drops, causing hypotension. The hypotensive effect is also linked to the release of nitric oxide in a dose-dependent manner, which facilitates vascular relaxation. Poisoning by any centrally acting antihypertensive medication presents with signs and symptoms that are similar, primarily due to an exaggerated pharmacological effect. Common indications include depression of the central nervous system, which can range from mild lethargy to profound coma. Severely affected patients may experience decreased ventilatory effort, leading to hypoxia, characterized by slow, shallow respirations or periodic cessation of breathing. This hypoventilation often responds to tactile stimuli in children. However, in severe cases, mechanical ventilation may be necessary. Typically, central nervous system depression resolves within 12 to 36 hours. Additional manifestations include decreased muscle tone, reduced reflex activity, and irritability. Bradycardia, or a slow heart rate, can occur in up to 50% of patients. It results from an exaggerated central nervous system mediated effects that decrease sympathetic activity, increased vagal tone, or direct stimulation of the heart's alpha-2 adrenergic receptors. Other conduction abnormalities, such as various degrees of heart block, have also been observed. Hypotension is the primary cardiovascular manifestation of toxicity. Even small ingestions such as 0.2 milligrams of clonidine can lead to severe poisoning. Hypothermia, which is associated with overdoses, is believed to result from alpha-adrenergic effects within the thermoregulatory center or from activation of central serotonergic pathways. It rarely requires treatment and typically responds well to passive rewarming. Miosis or pinpoint pupils is a common symptom. However, mydriasis or pupil dilation may occasionally occur. There are rare reports of seizures associated with poisoning. Since methyl-dopa is a prodrug, it may cause delayed toxicity. Fatalities due to these toxicities are rare. Clonidine and other centrally acting antihypertensives are not routinely included in serum or urine toxicologic assays. Therefore, management decisions should be based on clinical parameters. There are no specific electrolyte or hematologic abnormalities associated with this exposure. Due to the potential for bradydysrhythmia and hypoventilation, a 12-lead electrocardiogram and continuous cardiac and pulse oximetry monitoring are recommended. Management of toxicity begins with a focus on the patient's respiratory and hemodynamic status. Activated charcoal is the primary mode of gastrointestinal decontamination in most ingestions, although caution is advised due to the potential for central nervous system depression and aspiration. For clonidine patch ingestions, whole bowel irrigation may be effective. Patients should be fully exposed, examined for trauma, and any adherent patches removed. Patients with central nervous system depression should be evaluated for hypoxia and hypoglycemia. Those with respiratory compromise often respond to simple auditory or tactile stimulation. Endotracheal intubation should be performed if clinically indicated. Isolated hypotension should initially be treated with intravenous boluses of crystalloid. Bradycardia is typically mild and may not require therapy if perfusion is adequate. If symptomatic, atropine is often effective, but redosing may be required. Intravenous norepinephrine is an appropriate pressor for hypotension associated with bradycardia. Naloxone's role in managing antihypertensive overdoses, particularly those involving central-acting agents like clonidine and angiotensin-converting enzyme inhibitors, is frequently discussed, drawing parallels to its use in opioid poisoning. The initial rationale for using naloxone in poisonings with central-acting antihypertensives, such as clonidine, arose from the striking similarity of their clinical findings to those of opioid-poisoned patients. These similarities include central nervous system and respiratory depression and miosis. This led to speculation that the mechanism might involve the modulation of central nervous system sympathetic outflow by endogenous central nervous system opioids. Similarly, for angiotensin-converting enzyme inhibitors, the rationale for naloxone use is based on the idea that these drugs may inhibit the metabolism of enkephalin's endogenous opioids, thereby potentiating their opioid effects, which include lowering blood pressure. In cases of clonidine and other centrally acting antihypertensive overdoses, observed effects after naloxone administration include increased arousal, respiratory effort, heart rate, and blood pressure in clonidine-poisoned patients, particularly children. A clinical study showed that 0.4 milligrams of naloxone parenterally reversed the decrease in blood pressure and heart rate in almost 60% of hypertensive patients who had been given clonidine for 3 days. Despite these observations, reports on the efficacy of naloxone for imidazoline-induced toxicity are inconsistent. The observed responses are often transient and consistent with the natural cyclical course of the intoxication itself. One case involving a 3-year-old child who ingested tetrahydrozoline and imidazoline showed transient improvement after naloxone, but the child recovered fully without further doses, suggesting the response might have been due to the cyclical nature of the poisoning or physical stimulation. When clinical improvement occurs, it may necessitate high doses of naloxone 4 to 10 milligrams, similar to what is sometimes seen with certain synthetic opioids. Due to naloxone's short duration of effect, 20 to 60 minutes, redosing or a continuous infusion may be required. There have been reports of hypertension occurring in clonidine-poisoned children after naloxone administration. Despite the lack of definitive controlled clinical trials proving its benefit, an empirical trial of relatively high-dose naloxone, 0.4 to 10 milligrams intravenously, is considered reasonable in cases of imidazoline intoxication, especially if impending endotracheal intubation is a concern due to respiratory depression refractory to physical stimulation. However, this intervention should not delay the institution of appropriate supportive care measures. The sources suggest that the most appropriate empirical use of naloxone in this setting is to address the possibility of unrecognized or concomitant opioid toxicity. Hypertension that occurs early in life is typically self-limited, and treatment should be approached cautiously. If the condition is severe or persists for an extended period, it is appropriate to use short-acting, titratable antihypertensive medications such as intravenous nicardipine or sodium nitroprusside. Certain medications like esmolol and other beta blockers are contraindicated because they can worsen paradoxical hypertension by causing unopposed alpha-1 receptor stimulation, similar to the effects seen with cocaine toxicity. Oral nifedipine is also not recommended as it cannot be easily titrated and has unpredictable efficacy. Hypothermia, on the other hand, responds well to passive rewarming methods. Regarding antagonists, tolazoline and yohimbine are generally not recommended due to mixed clinical experiences and reported adverse effects, including hypertension, tachycardia, and arrhythmias. Abrupt discontinuation of central antihypertensive therapy can lead to a withdrawal syndrome characterized by excessive sympathetic nervous system activity. Symptoms usually start between 16 to 48 hours after stopping the medication and may include agitation, difficulty sleeping, tremors, rapid heartbeats, increased heart rate, and high blood pressure. In some cases, ventricular tachycardia and heart attacks can also occur. The severity and frequency of these symptoms tend to be higher in patients who have been on higher doses of medication for several months or who had severe high blood pressure before treatment. Medications with shorter durations of action, such as certain drugs like clonidine and guanabens, are more commonly associated with withdrawal symptoms. The underlying mechanism involves increased activity of norepinephrine in the central nervous system, coupled with decreased sensitivity of alpha-2 receptors. Treatment typically involves reintroducing clonidine or benzodiazepines, followed by a gradual reduction of medication. It is important to note that beta-adrenergic blockers, including labetalol and esmolol, are generally contraindicated in cases of clonidine withdrawal because they can worsen paradoxical high blood pressure by causing unopposed stimulation of alpha-1 receptors. Pediatric patients, particularly infants and young children, are especially vulnerable to systemic effects from the topical use of imidazoline medications due to their smaller body mass and the inadequacy of packaging for proper dosing. These children are at a higher risk of experiencing central nervous system depression and respiratory failure. Geriatric patients or elderly individuals may also face an increased risk of systemic adverse effects from topical imidazoline applications, with some reports indicating occurrences of slow heart rate and low blood pressure. Regarding pregnant patients, clonidine, one of the imidazoline drugs, easily crosses the placenta, resulting in fetal blood levels that are similar to maternal levels. During labor, the use of epidural clonidine can lead to fetal slow heart rate. Although typically not associated with significant adverse effects when used at non-toxic doses during pregnancy, there has been a case report suggesting the potential for severe birth defects, specifically Roberts syndrome, associated with clonidine use during pregnancy. Consequently, it is advisable to consider alternative medications. Clonidine is also secreted in breast milk, which poses additional considerations. The use of oxymetazoline in pregnant women has been linked to changes in fetal heart rate. Overall, the safest approach is to advise against the use of imidazoline medications during pregnancy. Moxonidine and rilmenidine are considered second-generation, centrally acting antihypertensive medications, representing the newest class available in the United States. These drugs are structurally similar to clonidine, but selectively target I1 imidazoline binding sites with much less affinity for the alpha-2 adrenergic receptor. While their exact mechanism is still being investigated, binding to these sites leads to a reduction in sympathetic outflow, vasodilation, and a decrease in blood pressure. They also have a more favorable side effect profile than clonidine. Patients with diabetes or metabolic syndrome may particularly benefit from moxonidine due to its positive effects on insulin resistance, impaired glucose tolerance, and hyperlipidemia. One overdose case reported initial hypertension and somnolence, suggesting that weak alpha-2 adrenergic receptor affinity can be overwhelmed in an overdose situation. Dexmedetomidine is a selective alpha-2 adrenergic agonist that also possesses affinity for imidazoline receptors. It is widely used for short-term perioperative and critical care sedation, analgesia, anxiolysis, and amnesia, and to reduce anesthetic and opioid requirements. Dexmedetomidine is several-fold more specific for the alpha-2 adrenoceptor than clonidine, with an alpha-2 to alpha-1 activity ratio of 16:20:1 compared to 2:20:1 for clonidine. Its hemodynamic effects may be reversible with vasoactive medications. Adverse effects include hypotension, transient hypertension upon loading, nausea, bradycardia, atrial fibrillation, and hypoxia. First or second-degree atrioventricular block has been observed. Overdoses have been reported due to medication errors. Clinical manifestations of overdose include meiosis, bradypnea, bradycardia, hypotension, and deep sedation, which can lead to unconsciousness. It has been successfully used in the management of alcohol and baclofen withdrawal. Concerns exist regarding its potential for adrenal suppression and increased mortality, similar to etomidate, though studies suggest its effect is less significant. Understanding the diverse mechanisms of action and the unique toxicological considerations for each antihypertensive agent is important. While many antihypertensive medications primarily cause signs and symptoms based on the degree of hypotension produced, centrally acting agents like clonidine present a distinct toxidrome mimicking opioid poisoning with significant central nervous system and cardiovascular effects. Newer centrally acting agents like moxonidine, rilmenidine, and dexmedetomidine offer improved selectivity and therapeutic benefits, but require careful attention to their specific pharmacology and potential toxicities. Expanding beyond these centrally acting agents, the sources also explore other sympatholytic antihypertensive medications, as well as additional first-generation drugs such as direct vasodilators, including sodium nitroprusside and diuretics. These categories offer distinct mechanisms of action and present unique toxicological considerations. The broader classification of sympatholytic antihypertensives encompasses several drug classes that work by reducing blood pressure through diminishing the effects of the sympathetic nervous system. These drugs are categorized based on their mechanism of action, including ganglionic blockers, presynaptic adrenergic blockers, and alpha-1 adrenergic antagonists. However, the sources note that these medications are rarely used in clinical practice today. Consequently, less is known about their effects in overdose situations compared to more commonly prescribed agents. Presynaptic adrenergic antagonists are agents that decrease blood pressure by reducing the release of norepinephrine from nerve terminals. Guanethidine and guanidrol interfere with the action potentials responsible for triggering norepinephrine release. Reserpine, another such agent, depletes norepinephrine, serotonin, and other catecholamines from presynaptic nerve terminals, likely by directly binding to and inactivating the storage vesicles that contain these neurotransmitters. The adverse effects associated with these medications are significant. clinical usefulness is limited by several side effects, including a high incidence of orthostatic hypotension, which is a drop in blood pressure upon standing, as well as hypotension induced by exercise. Patients may also experience diarrhea, increased gastric secretions, and impotence. The hypotensive effects of these medications can be prolonged, sometimes lasting up to a week. Reserpine has particular effects due to its ability to cross the blood-brain barrier. It can deplete catecholamines not only in the peripheral nervous system, but also within the central nervous system. This central depletion can lead to symptoms such as drowsiness, extrapyramidal symptoms, hallucinations, migraines, and depression. In cases of overdose, an exaggeration of these pharmacological effects is expected. Patients are likely to develop severe orthostatic hypotension, which should be managed with intravenous crystalloid fluid boluses and the administration of vasopressors that act directly to constrict blood vessels. If reserpine is involved, significant central nervous system depression may also occur, necessitating careful monitoring and supportive care. Peripheral alpha-1 adrenergic antagonists are selective alpha-1 adrenergic antagonists. These drugs work by blocking the alpha-1 receptor, a postsynaptic receptor primarily found on vascular smooth muscle, as well as in the eye, gastrointestinal, and genitourinary tracts. By blocking these receptors, they cause arterial smooth muscle relaxation, vasodilation, and a reduction in blood pressure. Common examples of these drugs include prazosin, terazosin, and doxazosin. Silodosin is also listed. These agents are also first-line pharmacological therapy for patients with urinary dysfunction due to benign prostatic hyperplasia. Although generally better tolerated than other sympatholytics, they can still cause significant symptoms of postural hypotension, including lightheadedness, syncope, or palpitations. These effects are particularly noted after the first dose or with rapid dose increases. Overdose reports for these medications include hypotension and central nervous system depression, ranging from lethargy to coma. Priapism may also occur. Management of an overdose involves supportive care, intravenous crystalloid boluses, and a vasopressor like phenylephrine, which is considered a logical initial choice due to its peripheral alpha-adrenergic agonist activity. Direct vasodilators represent a first generation of antihypertensives introduced when asymptomatic hypertension was first linked to severe adverse effects like stroke and myocardial infarction. While effective, these agents often had significant adverse events, which led to the development of newer classes of antihypertensives. Despite this, direct vasodilators, along with other sympatholytics, are characterized by their limited use clinically today, and consequently, less is known about their effects in overdose. The primary direct vasodilators discussed are hydralazine, minoxidil, and sodium nitroprusside. Diazoxide is also mentioned. Direct vasodilators primarily induce vascular smooth muscle relaxation independent of innervation or known pharmacologic receptors. For most agents in this class, the vasodilatory effect is attributed to the stimulation of nitric oxide release from vascular endothelial cells. This nitric oxide then diffuses into underlying smooth muscle cells, stimulating guanylate cyclase to produce cyclic guanosine monophosphate. Cyclic guanosine monophosphate indirectly inhibits calcium entry into the smooth muscle cells, which leads to vasodilation. In addition to the nitric oxide pathway, minoxidil also has direct potassium channel activation effects. It is proposed that the opening of adenosine triphosphate-linked potassium channels results in potassium influx and cell depolarization, thereby reducing calcium influx and ultimately relaxing vascular smooth muscle. As vasodilation occurs, the body's baroreceptor reflexes remain intact and are stimulated, leading to an increased sympathetic outflow to the myocardium. This results in a reflex increase in heart rate and contractile force tachycardia. Therapeutically, these agents are often used in patients with severe refractory hypertension and typically in conjunction with a beta-adrenergic antagonist to mitigate this reflex tachycardia. Hydralazine, minoxidil, and diazoxide are effective when administered orally. Sodium nitroprusside, however, is only used intravenously. Minoxidil is also used topically as a 2% solution to promote hair growth. Diazoxide was historically used to rapidly reduce blood pressure in hypertensive emergencies, but is rarely used for this indication now. This is due to its poor ability to be titrated and its variable, sometimes profound, hypotensive effect. The potential for sodium nitroprusside to cause cyanide poisoning, coupled with the introduction of other equally effective and rapidly titratable antihypertensives, has significantly reduced its use. The clinical signs and symptoms of most antihypertensives, including direct vasodilators, are primarily determined by the severity of hypotension they induce. The toxic manifestations of direct vasodilators and overdose are essentially an amplification of their intended pharmacological effects. Patients may experience lightheadedness, syncope, palpitations, and nausea. Observable signs can include tachycardia, flushing, or changes in mental status, all of which correlate with the degree of hypotension. When considering specific agents, hydralazine, with its daily use, is linked to several immunological phenomena. These include hemolytic anemia, vasculitis, acute glomerulonephritis, and most notably a lupus-like syndrome. Minoxidil can cause electrocardiogram changes such as sinus tachycardia, ST segment depression, and T-wave inversion, both at therapeutic and overdose levels. There appears to be a link between supratherapeutic doses of minoxidil and multifocal subacute necrosis of the left ventricle followed by fibrosis. Although the significance of these changes is not yet understood, they typically resolve. Interestingly, recent years have seen the majority of reported exposures to this class of drugs involving the topical formulation of minoxidil. Sodium nitroprusside is a prodrug that releases nitric oxide and contains 5 cyanide radicals. The gradual release of these radicals may lead to cyanide or thiocyanate toxicity. Physiologic methemoglobin can bind liberated cyanide. However, this capacity may be overwhelmed. Cyanide moieties are rapidly cleared through interaction with sulfhydryl groups and enzymatic conversion in the liver by rhodinase, which converts them to thiocyanate using thiosulfate. Factors that deplete sulfur donor stores, such as malnutrition, critical illness surgery, and diuretic use, increase the risk of cyanide toxicity. Hemolysis associated with cardiopulmonary bypass may also accelerate cyanide release. Infusion rates exceeding 4 micrograms per kilogram per minute for more than 12 hours may overwhelm the detoxification capacity. Signs and symptoms of cyanide toxicity include altered mental status, anion gap metabolic acidosis, and in advanced stages hemodynamic instability. The thiocyanate formed as a detoxification product may accumulate, particularly in patients with renal insufficiency, leading to thiocyanate toxicity. Thiocyanate is almost exclusively eliminated renally, with a long half-life of 3 to 7 days. Nonspecific symptoms, which can manifest at serum concentrations of 60 micrograms per milliliter, include nausea, vomiting, fatigue, dizziness, confusion, delirium, and seizures. Life-threatening effects, such as hemodynamic instability and intracranial pressure elevation, may occur at serum concentrations above 200 micrograms per milliliter. Notably, anion gap metabolic acidosis and hemodynamic instability do not occur with thiocyanate toxicity, which distinguishes it from cyanide toxicity. If a patient experiences a direct vasodilator overdose, the appropriate therapy involves routine supportive care focused on maintaining adequate mean arterial pressure following appropriate gastrointestinal decontamination. Hypotension is initially treated with intravenous crystalloid boluses. If crystalloids are insufficient, a peripherally acting alpha-adrenergic agonist, such as norepinephrine or phenylephrine, is an appropriate next step. Dopamine and epinephrine should be avoided to prevent an exaggerated myocardial response and tachycardia from beta-adrenergic stimulation. Cyanide toxicity, a potential complication of nitroprusside, can be prevented by the concomitant administration of sodium thiosulfate, 1 gram for every 100 milligrams of nitroprusside, to expand the thiosulfate pool for detoxification. This does not interfere with the vasodilatory effects. Simultaneous infusion of hydroxycobalamin, 25 milligrams per hour, has also successfully reduced cyanide poisoning. However, due to its higher cost and interactions with laboratory tests, thiosulfate remains the mainstay of prophylaxis. If cyanide poisoning occurs, hydroxycobalamin is the current treatment of choice. For thiocyanate toxicity, also from nitroprusside, thiocyanate concentrations can be beneficial for monitoring critically ill patients at risk. Hemodialysis effectively clears thiocyanate from the serum and should be strongly considered in patients with significant clinical manifestations. Diuretics were among the first-generation antihypertensives developed in the 1960s. They were created to combat the severe adverse effects linked to asymptomatic high blood pressure such as stroke and heart attack. Diuretics are broadly categorized into three main groups based on their primary sites of action in the kidney. Thiazides and related compounds, such as hydrochlorothiazide and chlorthalidone, exert their diuretic effect by inhibiting sodium and chloride reabsorption in the distal convoluted tubule. Loop diuretics, including furosemide, bumetanide, and ethacrynic acid, inhibit the coupled transport of sodium, potassium, and chloride in the thick ascending limb of the loop of Henle. Their mechanism for lowering blood pressure, while not entirely clear, involves increased urinary excretion of sodium, potassium, and magnesium. Potassium-sparing diuretics, a group that includes amiloride, triamterene, and spironolactone, act either as aldosterone antagonists, for example spironolactone, or as renal epithelial sodium channel antagonists, for example triamterene, in the late distal tubule and collecting duct. Two other diuretic groups, carbonic anhydrase inhibitors, for example acetazolamide, and osmotic diuretics, for example mannitol, are not primarily used as agents for lowering blood pressure. The majority of toxicity associated with diuretics is metabolic, typically occurring during chronic therapy or overuse rather than acute overdose. Common metabolic abnormalities include hyponatremia, hypokalemia, hypomagnesemia, hyperkalemia, hyperglycemia, hyperuricemia, renal calculi, and gout. Hyponatremia can develop within the first 2 weeks of initiating diuretic therapy in over 2/3 of susceptible patients. Female sex, old age, and malnourishment are identified as the greatest risk factors. Severe hyponatremia, serum sodium less than 120 milliequivalents per liter, can manifest with symptoms like headache, nausea, vomiting, confusion, seizures, or coma. Rapid correction of severe hyponatremia, especially due to diuretic abuse, carries the risk of osmotic demyelination syndrome, central pontine myelinolysis. Hypokalemia and hypomagnesemia are electrolyte imbalances associated with diuretic use that may precipitate ventricular dysrhythmia such as Torsades points and potentially sudden death. While the exact risk is controversial, monitoring and correcting potassium levels are considered prudent, especially in elderly patients and those concurrently taking digoxin, where hypokalemia clearly exacerbates dysrhythmias. Hyperkalemia is a potential side effect of potassium-sparing diuretics, particularly in patients with renal insufficiency or when combined with other hyperkalemia-producing drugs like angiotensin-converting enzyme inhibitors. Thiazide diuretics are associated with inducing hyperglycemia, particularly in patients with diabetes mellitus. This effect is thought to result from the depletion of total body potassium stores, which reduces insulin secretion, as insulin secretion is dependent on transmembrane potassium fluxes. This effect is dose-dependent and reversible with potassium supplementation or discontinuation of the thiazide diuretic. This association has led to debate regarding the routine use of thiazide diuretics as first-line antihypertensives in uncomplicated patients. Thiazide diuretics can induce hyperuricemia, renal calculi, and gout, because diuretic-induced volume depletion reduces uric acid filtration and increases its proximal tubule reabsorption. This is due to uric acid elimination being dependent on intravascular and urinary volume. Several unusual reactions associated with thiazide diuretic use include pancreatitis, cholecystitis, and hematologic abnormalities like hypercoagulability, thrombocytopenia, and hemolytic anemia. Despite their widespread use, acute overdoses of diuretics are quite rare. The major signs and symptoms of overdose typically reflect the pharmacologic action of the drugs and may include gastrointestinal distress, rapid and excessive urination, possible low blood volume, electrolyte imbalances, and altered mental status. Usually, the diuretic effects are temporary because of their limited duration and the body's rapid clearance of these medications. Management of diuretic overdose primarily involves supportive care. It is crucial to assess and correct fluid and electrolyte imbalances promptly. In cases where unexpected high potassium levels are detected, consideration should be given to the ingestion of potassium-sparing diuretics or, more often, potassium supplements. These supplements are commonly prescribed alongside thiazide and loop diuretics. Altered mental status, including coma, may occur even in the absence of fluid or electrolyte abnormalities. This could be due to a direct effect of the drug or a transient reduction in brain blood flow caused by low blood pressure. Angiotensin-converting enzyme inhibitors are a significant class of antihypertensives that emerged after the first generation of drugs in the 1960s. They are among the most widely prescribed antihypertensives, with numerous agents approved by the United States Food and Drug Administration, including benazepril, captopril, enalapril, fosinapril, lisinopril, moexapril, perindopril, quinapril, ramipril, spirapril, and trandolapril. Angiotensin-converting enzyme inhibitors work by inhibiting the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor and stimulates aldosterone secretion. By blocking its formation, angiotensin-converting enzyme inhibitors lead to vasodilation, decreased peripheral vascular resistance, reduced blood pressure, and increased cardiac output. This also results in a relative increase in renal, cerebral, and coronary blood flow. Furthermore, angiotensin-converting enzyme also inactivates bradykinin and substance P. Therefore, angiotensin-converting enzyme inhibition results in elevated bradykinin concentrations, which is identified as the primary cause of both angiotensin-converting enzyme inhibitor-induced angioedema and cough. Most angiotensin-converting enzyme inhibitors are well absorbed from the gastrointestinal tract, achieving peak serum concentrations within 1 to 4 hours. Enalapril and ramipril are prodrugs that require hepatic metabolism to become active. Elimination of angiotensin-converting enzyme inhibitors is primarily via the kidneys. While generally well tolerated with a very low incidence of side effects, some reported adverse events include rash, dysgeusia, taste disturbance, neutropenia, hyperkalemia, chronic cough, and angioedema. A significant concern is their teratogenic potential, meaning angiotensin-converting enzyme inhibitors are potential teratogens and should never be used by pregnant women or women of childbearing age. Severe hypotension leading to syncope and cardiac ischemia can occur in select patients after their initial dose, particularly in those with renovascular hypertension or hypovolemia due to diuretic use. Acute overdoses of angiotensin-converting enzyme inhibitors appear to have limited toxicity, with fatalities rarely reported in isolated ingestions. Many patients may remain asymptomatic despite high serum drug concentrations. When toxicity does occur, it is typically hypotension. Management of ACI overdose primarily focuses on supportive care and identifying any more toxic co-ingestants. Gastrointestinal decontamination with activated charcoal alone is often sufficient. For hypotension, intravenous crystalloid boluses are generally effective. In rare cases, catecholamines may be required. Naloxone may be effective in reversing the hypotensive effects of angiotensin-converting enzyme inhibitors. This is theorized to occur because angiotensin-converting enzyme inhibitors may inhibit the metabolism of enkephalins, which are endogenous opioids that can lower blood pressure. While studies and case reports suggest its efficacy in blunting hypotensive responses or reversing symptomatic hypotension, other reports indicate it can be ineffective. Its role remains unclear, but it may be considered to potentially reduce the need for large volumes of crystalloid or vasopressors. Methylene blue has been explored as a promising new treatment for hypotension produced by angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, particularly in patients undergoing cardiopulmonary bypass where vasodilation is exacerbated by angiotensin-converting enzyme inhibitors. It appears to increase mean arterial pressure and systemic vascular resistance. A reasonable starting dose is 2 milligrams per kilogram, with subsequent boluses or continuous infusions. Angiotensin II receptor blockers, ARBs, are agents developed for their improved efficacy and adverse event profiles. Their mechanism of action involves antagonizing angiotensin II at the type 1 angiotensin at 1 receptor. This differs from angiotensin-converting enzyme inhibitors, ASEs, because ARBs decrease the effects of angiotensin II rather than decreasing its formation. By blocking the AT1 receptor, ARBs inhibit the vasoconstrictive and aldosterone-promoting effects of angiotensin II. This ultimately leads to a reduction in blood pressure by blunting both the sympathetic and the renin-angiotensin systems. ARBs are rapidly absorbed from the gastrointestinal tract, typically reaching peak serum concentrations within 1 to 4 hours. Their elimination primarily occurs either unchanged in the feces or after hepatic metabolism via the mixed-function oxidase system, with subsequent elimination in the bile. Examples of ARBs marketed in the United States include azulsartan, candesartan, epirsartan, irbesartan, losartan, olmesartan, telmisartan, and valsartan. Therapeutically, ARBs are used to manage hypertension, similar to other classes of antihypertensives. They are part of the broader renin-angiotensin-aldosterone system, RAS, acting antihypertensives, which also include ASEs and direct renin inhibitors, DRIs. While ARBs generally have a similar side effect profile to ASEs, there are important distinctions and concerns. Despite mechanistic evidence suggesting that ARBs, unlike ASEs, do not affect bradykinin degradation and should therefore have a much lower incidence of angioedema, serious cases of angioedema associated with ARB therapy have been reported. The incidence of angioedema is significantly higher with ARBs compared to other antihypertensives like beta-adrenergic antagonists. Similar to ASEs, ARBs are considered potential teratogens and should never be used by pregnant patients or women of childbearing age. When initiating ARB therapy, up to 1% of patients may develop first-dose orthostatic hypotension. Published reports of angiotensin receptor blocker ARB overdoses are few. The adverse signs and symptoms observed in overdose are generally an extension of their therapeutic effects, primarily reflecting orthostatic or absolute hypotension. These symptoms may include palpitations, diaphoresis, dizziness, lethargy, or confusion. Management of ARB overdose focuses on supportive care. Hypotension should initially be treated with intravenous crystalloid boluses. If intravenous crystalloids are insufficient, catecholamine therapy may be required. Patients chronically taking ARBs may exhibit significant hypotension during induction of general anesthesia that has been refractory to traditional vasoconstrictor therapy such as norepinephrine, ephedrine, or phenylephrine. A promising new treatment for this refractory hypotension, also seen with angiotensin-converting enzyme inhibitors, ASEs, is methylene blue. This treatment was first explored in patients undergoing cardiopulmonary bypass where systemic blood pressure and peripheral vascular resistance decrease due to various factors, including increased bradykinin. Since ASEs and ARBs exacerbate this vasodilation by inhibiting bradykinin metabolism, methylene blue, which increases mean arterial pressure and systemic vascular resistance, may be beneficial. A reasonable starting dose of methylene blue as a vasopressor appears to be 2 milligrams per kilogram, with subsequent intermittent boluses or continuous infusions starting at 0.5 milligrams per kilogram per hour. Refractory hypotension in chronically ARB-treated patients has also been reported to respond to vasopressin. ARBs are a modern class of antihypertensives that specifically target the AT1 receptor to lower blood pressure. While generally well tolerated, they carry risks of angioedema and teratogenicity. Overdoses primarily cause hypotension, which is managed with fluids, conventional vasopressors, and potentially methylene blue or vasopressin in refractory cases. Direct renin inhibitors are a newer class of antihypertensive agents. They emerged after the development of first-generation drugs like beta-adrenergic antagonists, calcium channel blockers, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers. DRIs, such as aliskiren, primarily lower blood pressure by directly inhibiting circulating renin within the renin-angiotensin-aldosterone system, RAS. This direct inhibition is notable because, while all RAS-acting antihypertensives cause a compensatory increase in serum renin concentrations, only DRIs can blunt the physiologic effects of this rise. Aliskiren is described as well-tolerated and effective when used alone for hypertension. It can also be used in combination with other blood pressure medications, including hydrochlorothiazide, a diuretic, calcium channel blockers, and beta-adrenergic antagonists. A significant controversy surrounds the use of aliskiren when combined with ARBs or ASAs. A clinical trial involving patients with diabetes and chronic kidney disease who were receiving such combination therapy was halted due to an increased incidence of ischemic stroke, acute kidney injury, high potassium levels, and low blood pressure. This highlights a crucial safety consideration for combination therapy involving multiple RAS-acting agents. Toxicity and overdose potential of dietary reference intakes, DRIs, are generally considered to be low, and they are rarely associated with severe poisoning. According to available sources, there have been no reported cases of poisoning or overdose directly involving DRIs. Despite the lack of reported overdose instances, it is important to anticipate the possibility of low blood pressure or hypotension in the event of an overdose. Management of a suspected overdose of dietary reference intakes typically involve supportive care measures. This can include the administration of intravenous crystalloids to maintain fluid balance, and, if necessary, the use of medications such as catecholamines to support cardiovascular function. This educational module on antihypertensive pharmacotherapy and toxicology emphasizes understanding the evolution of these agents and their unique toxicologic considerations. Pharmacotherapy for hypertension began in the 1960s. First-generation agents included centrally acting sympatholytics, direct vasodilators, sodium nitroprusside, and diuretics. Newer agents with improved profiles include beta-adrenergic antagonists, calcium channel blockers, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and direct renin inhibitors. Most antihypertensives primarily manifest clinical signs and symptoms based on the degree of hypotension produced. Centrally acting sympatholytics, such as clonidine and methyl-dopa, stimulate presynaptic alpha-2 adrenergic receptors in the brain, decreasing norepinephrine release and sympathetic outflow. Structurally similar imidazoline compounds can also produce systemic effects. Their use is increasing for various applications beyond hypertension, including attention deficit/hyperactivity disorder and withdrawal management. Overdose causes significant toxicity, especially in children, with a distinct toxidrome mimicking opioid poisoning, central nervous system depression, potentially leading to respiratory compromise, bradycardia, hypotension, and meiosis. Naloxone may increase arousal and improve vital signs, particularly in children, but its efficacy is inconsistent and often transient. An empirical trial is considered reasonable for respiratory depression refractory to stimulation or to address concomitant opioid toxicity, but it should not delay supportive care. High doses 0.4 to 10 milligrams intravenously, and redosing may be required. Withdrawal syndrome from abrupt cessation involves excessive sympathetic activity, agitation, hypertension, tachycardia. Beta-adrenergic antagonists are contraindicated as they can exacerbate paradoxical hypertension. Newer agents like moxonidine, rilmenidine, and dexmedetomidine selectively target imidazoline receptors or are highly selective alpha-2 agonists, offering improved profiles, but still presenting with sedation and hemodynamic effects in overdose. Pediatric, geriatric, and pregnant patients are at increased risk of systemic adverse effects from topical or therapeutic imidazoline use. Imidazoline use in pregnancy is generally advised against. Other sympatholytics, including presynaptic adrenergic antagonists and peripheral alpha-1 adrenergic antagonists, are rarely used clinically. Presynaptic agents such as reserpine deplete norepinephrine, causing severe orthostatic hypotension and central nervous system depression. Peripheral alpha-1 antagonists such as prazosin cause vasodilation and hypotension, potentially with central nervous system depression and priapism. Management is supportive with fluids and vasopressors. Direct vasodilators such as hydralazine, minoxidil, and sodium nitroprusside cause vascular smooth muscle relaxation, primarily via nitric oxide release, leading to a reflex increase in heart rate. Sodium nitroprusside is a key concern due to its release of cyanide radicals, leading to potential cyanide or thiocyanate toxicity. Cyanide toxicity presents with altered mental status, anion gap metabolic acidosis, and hemodynamic instability, treated with hydroxycobalamin or thiosulfate prophylaxis. Thiocyanate toxicity, due to renal accumulation, causes nonspecific symptoms but lacks metabolic acidosis and hemodynamic instability, and is treated with hemodialysis. Hydralazine is associated with a lupus-like syndrome. Minoxidil can cause electrocardiogram changes. Management for overdose is supportive, using intravenous crystalloids and peripherally acting alpha-adrenergic agonists for hypotension. Diuretics, including thiazides, loop diuretics, and potassium-sparing diuretics, primarily cause metabolic toxicity, occurring mainly during chronic therapy or overuse rather than acute overdose. Common abnormalities include hyponatremia, hypokalemia, hypomagnesemia, potentially leading to dysrhythmias, hyperkalemia with potassium-sparing diuretics, hyperglycemia, thiazides, and hyperuricemia/gout. Acute overdose is rare and typically managed with supportive care focused on fluid and electrolyte status. For renin-angiotensin-aldosterone system inhibitors, angiotensin-converting enzyme inhibitors such as lisinopril inhibit angiotensin I-to-2 conversion, increasing bradykinin, which causes vasodilation. Key adverse effects include angioedema, chronic cough, hyperkalemia, and teratogenicity. Acute overdose toxicity is often limited to hypotension, managed supportively. Naloxone and methylene blue have been explored for refractory hypotension. Angiotensin receptor blockers, such as losartan, antagonize angiotensin II at the AT1 receptor. They also carry risks of angioedema, despite mechanistic differences and teratogenicity. Overdose primarily causes hypotension, managed with fluids, conventional vasopressors, and potentially methylene blue or vasopressin for refractory cases. Direct renin inhibitors, such as aliskiren, directly inhibit renin. They generally have limited toxicity with no reported overdoses. However, combination therapy with angiotensin-converting enzyme inhibitors or angiotensin receptor blockers is associated with increased risks of ischemic stroke, acute kidney injury, hyperkalemia, and hypotension. Hypotension is anticipated in overdose, managed supportively.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.